obviously a little bit decline somewhat with older age, but they have great recall on their long-term memory. So, moving forward to the next slide, I'd like to start talking about the frail elderly. In this class, we're going to be talking about things called syndromes, geriatric syndromes. There are some common geriatric syndromes that are frequently seen among older adults. A syndrome is a series of symptoms and characteristics that don't fall into a particular disease category. All right, and one of the syndromes that we're addressing right now is frailty. Um, there is a group of older adults who fall into the frail elderly syndrome. And individuals who fall into that category, as you can see, will have a presence of 3 or more of the following, whether it's an unplanned weight loss of 10 or more pounds in the past year. They are weak, exceptionally weak. They have poor endurance and energy. They have specific slowness, and they have low activity. Now, falling into that frail elderly syndrome puts in, individuals who fall in that category are very vulnerable for further decline. They have problems coping with their declining functional abilities and with decreased daily energy. So anything else that's superimposed upon them when they're in this state of frailty really taxes their ability to deal with that, and they end up becoming ill because they have diminished reserve and they have a decreased ability to respond to the stress because they're in that current state of frailty. All right, so again, they're at risk for disability, they're at risk for disease, for becoming ill because of their state of frailty. We can see there are certain risk factors that are associated with the frail elderly syndrome: age, individuals with disabilities, individuals with multiple chronic illnesses, those who have dementia, people who smoke, individuals with a history of depression, and people who are underweight are more at risk for falling in that frail elderly syndrome, where any additional stress or illness can result in further decline and disability. All right. Very, very important for the frail older adult is for us to assess and manage their nutrition and their hydration. Older adults have a decreased reflex for drinking, for thirst. They don't recognize that their body is becoming dehydrated. Their body doesn't tell them, you're thirsty, you need to drink. So there are very frequently hydration issues, and the older adult that is in the frail category is also at risk for malnutrition. So we want to be sure that we're assessing their nutritional status on a regular basis. So here's an acronym. It's called SCALES, and we want to monitor any sadness or mood changes that can result in a nutritional decline. We want to monitor cholesterol. We want to make sure that calories that older adults are consuming are healthy, high energy calories. Individuals with high cholesterol may be having additional problems somewhere. We know that a low albumin we know that is not good. Low albumin is in fact, a risk factor for older adult mortality. And an admission, in an acute care setting, an admission serum albumin for the OA is actually a predictor of outcomes. So the normal albumin level is 3.5 to 5, and we know that the levels do decline with age, and albumin is a significant indicator of nutritional decline. We, of course, monitor for loss of weight or gain of weight. We know that obese individuals may not be well nourished. We want to observe for any kind of eating problems, whether it's related to appetite, whether it's related to physical ability to manage utensils, cut food. We want to monitor for the ability to masticate. Are the dentures present, missing, poorly fitting? Does the individual have rotting teeth that makes consuming nutrition difficult? So we monitor for any kind of eating problems. And also important for the older adult out in the community is making sure that they're able to get out, or someone gets out for them to get foods, and that foods can be prepared either by themselves or someone else. So these are some very key factors for us to be aware of when we're assessing individuals for nutritional status. Lots of nutritional problems arise from individuals who are older and live alone, individuals who are older and live alone and are depressed, and individuals who are older and have low income. So, some common interventions for those things might be hooking the individual up with some social services that are available in the community, having home delivered meals. There are several organizations that do that at nominal or low cost. Maybe the individual needs some dietary supplements that are high in protein, dental referrals, and of course we would always consider perhaps there might be a need for some dietary supplements as well. All right. Um, Social support for the older adult is key in their overall health and wellness. Primary levels of support come from family and friends. They are typically the preferred social support for the older adult. And often the caregivers for older adults can be a little bit older themselves as well. It depends upon what older age category we're talking about. The old who are in their 80s, or the middle old who are in their 70s, or the young old who are in their 60s. Um, the semi-formal social support that's out there for the older adult includes clubs, churches, neighborhoods, senior citizen centers, etc. And then there's, of course, formal social support in the form of welfare agencies, government support, health facilities, etc. There is a risk for the older adult in developing mental illness later in life when there's lack of social support or inadequate social support services. That can contribute to unresolved grief, excess stressors. It may be compounded by pre existing psychiatric illnesses, um, cognitive impairment, and inadequate coping resources. So, social support is really important. Another thing social support does for the older adult is it kind of helps keep a tally on how the older adult is doing. The older adult may not be recognizing that their appetite is poor, or that they're acting more depressed, or that their um, cognition is changing. But someone who sees them socially periodically may recognize that subtle change and say, "Hey, James, I know I'm your buddy and everything. I love seeing you here, each month. And hey, have you been eating okay? I noticed that you seem to have lost a little bit of weight. What's going on? Can you tell me about it?" So it can kind of be a point and check for that older adult, that social support system, to help identify potential decline and things that might be going wrong with the older adult that might not be discovered otherwise. Okay, a little bit about elder mistreatment and abuse. Unfortunately, it is a very real problem in our society today. Um, the elder mistreatment and abuse includes intentional acts against an older adult, or lack of doing things for an older adult. And we're going to go in some specific categories here. Um, these intentional acts or omissions are considered abuse or mistreatment if they cause harm or present a serious risk of harm to the older adult. failing to help the older adult meet their basic needs is considered a form of mistreatment and abuse as well. So let's just go through the list here. Physical abuse is pretty obvious. There are, situations where older adults are bruised, they're pushed, they're shoved, they're kind of, I hate to use the term manhandled, so I won't, but I think you get the idea they're handled roughly because we're of annoyance of some sort or for some other reason, I don't know. But another form of abuse would be oversedation with medications. All right, just let's sedate them, keep them out of my way. I don't have to deal with them. I'll sedate them. Restraints are also considered a form of physical abuse. In long-term care settings, especially, you will find that higher-rated long-term care facilities proudly present themselves as restraint-free facilities. We manage behavior problems and potential for falls differently, other than just using physical restraints. So, neglect is another type of elder mistreatment or form of abuse, and this includes failing to provide basic needs like food and clothing, shelter, um, medications that an individual might need because of a chronic illness, things like glasses and dentures. All right, failure to provide those is considered neglect. Psychological abuse can can include isolation. So, an adult child oversees the care for their older parent who lives alone, and they don't go by and check on them. All right, the older adult parent doesn't have any means of getting out. Nobody comes to see them, and the older adult child, who is the power of attorney, doesn't go by, doesn't check on them, doesn't call, doesn't do anything. That's a form of isolation, and it's considered psychological abuse. It's also a form of neglect, but there's some psychological abuse there as well. Also, a lot of older adults they suffer from intimidation. They are intimidated by their caregiver or their children. Their children threaten them in different ways. I'm not going to take care of you anymore if you don't do this, that, or the other thing. So psychological abuse. So you're no good. You're useless. You can just go on, and people who specialize in elder mistreatment and abuse, I'm sure, have horror stories that would bring tears to anyone's eyes. That's not my focus or my emphasis here, but rather than as registered nurses, we need to be aware that this is a very vulnerable population, and we need to know that our older adults are at great risk for experiencing mistreatment and abuse of various types. They're also at risk for financial abuse. Very often, the older adult children or care power of attorney, whether it's a friend or someone otherwise appointed, the older adult doesn't have access to their financial resources anymore. Someone else is making decisions for them, and that can be considered a form of abuse. Older adults are often coerced into signing things and giving things away that maybe they don't really want to, but they're intimidated or afraid that there'll be some sort of retaliation, they won't be cared for, so they concede and provide the signature. Violation of personal rights is also considered a form of mistreatment or abuse. Um, Denying the individual to a right of privacy, denying the right of the older adult to make decisions, and then, of course, there's abandonment. Again, not checking in on someone, um, you know, assigning them and their funds over to a nursing home, never checking in on them, um, leaving them, taking them out and dropping them off somewhere in a parking lot or in a shopping center, or just, that's a form of abandonment. And I know it happens, and it's very sad, and we just need to be sensitive to that. So the number of older adults who are mistreated isn't really known. A lot of it goes unreported by that older adult because they are afraid of retaliation. So that also is very important for us to be aware of. All right, mistreatment would continuation of that, there are actually several screening tools that are available. And if we go to the website that is on this slide, which is consultjerryrn.org. This is going to be a very important website for you this semester, and especially in your clinical. There's probably 50 or so evidence-based assessment tools specific for the older adult. And they are based on research, and they assist the nurse in identifying areas where the older adult is experiencing a decline or has a problem, so that we can better implement strategies to help the older adult deal with that. Here is an example of an elder mistreatment assessment tool. It gives you an idea of some of the things that we need to be looking for and be aware of as we're considering whether or not an individual is in fact experiencing some form of mistreatment. Um, we are responsible as professional nurses in detecting and reporting suspected abuse or actual abuse to the appropriate authorities. And in your early career as a nurse, you will report that to your supervisor, and together you'll make sure that the appropriate individuals are contacted to further document the suspicion. Um, Very important for anyone who you really feel strongly is at risk for, or is currently experiencing some form of mistreatment, is to make sure that that individual has a safety plan in place for their abuse. I'm sorry, somebody just came to the door, and I'm going to stop this here for just a minute. Okay, sorry for that interruption. I had an advisee who had some needs there. Anyway, what are some of the things that can put the older adult at risk for mistreatment? If you think about it, they have a tremendous need to depend on others because of either physical or cognitive decline. So that in and of itself places them at risk for mistreatment. They're dependent. Some of them, there's a higher prevalence of psychiatric diagnoses as we get older. Their potential use or misuse of alcohol or other substances. And there's, that decreased social support and isolation. So the nurse's role is very key in detecting and reporting any suspected or actual mistreatment or abuse. Alarmingly, it's very sad to realize by looking at this pie chart that we can identify here that the predominant abusers of our older adults are the children of the older adult themselves. So that's very sad. We can see a very small percentage are out-of-home service providers or in-home health care people or neighbors. The significant chunk of the abusers are the adult children. Very important for us to know over the years, the long-term care industry has undergone significant changes that have enhanced the quality of care that is available to our older adult population who rely on that type of service. And any bruise, any skin tear, anything like that is reportable to the director of nursing and to the family member. They actually have to make a phone call to the family member and say, Mrs. Smith, no alarm. I just needed to inform you that last night while we were assisting your mom to the bathroom, she bumped her elbow, and this morning there's a nice little bruise there. So when you come in and see her, we wanted you to be aware that that's where that bruise came from. And that's the process that's in place, and it does help protect that older adult from any type of abuse in that particular setting. If we flip to the next slide here, we've got a sample and exam question. An older man is having his blood pressure checked by the nurse at the senior center. where the nurse notes large bruises on both of his upper arms. And when questioned by the nurse about the cause of the bruises, the patient says, "Oh, I must have bumped myself." What is the best action for the nurse to do at that particular time? Now, if you take a few seconds to read through the choices, I'm going to share with you that the answer is, and you can pause this recording to do that and see if you can come up with the right answer yourself. But the correct answer is number three, to ask the patient to describe his living situation and usual activities while continuing with the assessment. So again, you're the nurse, you're checking the blood pressure, you're at the senior center. And so you've got this gentleman in front of you, and you notice these bruises, and asking him about them is just the beginning part of your assessment. You need to continue probing until you're satisfied that you've uncovered all of the appropriate information related to those bruises. Very typically, if someone is being physically abused in some way in their home environment, there's going to be more than one bruise. There's going to be more than one indicator that abuse is going on. So the nurse would continue with the assessment, drawing on her knowledge of some of those common signs that we as health professionals need to be aware of an individual who might be experiencing abuse. So, we're going to continue on with the assessment and ask the patient to, continue describing, oh, so where do you live, who do you live with, etc. Has anything changed, that sort of a thing. Number one is incorrect. All right, asking the patient if anyone in his family has been mistreating him at that point in time is premature. We haven't done enough of an assessment to ask the patient that question. Maybe later on, when we uncover more details that in fact are leading us to conclude, yes, I do think there is abuse going on, then we might ask that person. But we're not going to just right off the cuff say, hey, I see a bruise, are you getting beat up? Number two is incorrect. Again, pretty much the same rationale. We have not actually assessed that situation in detail enough to report anything. All right, is it reportable? We haven't done our homework yet. So make sure your assessment is thorough. Um, and then number four, reassuring the patient that information that he tells the nurse will be kept confidential. We cannot assure our patients when we're talking about suspected abuse, we cannot assure them that information that they share with us is going to be kept confidential. Whatever information we glean is reportable, and we have to share that with our patient and make sure that they know that whatever you tell me, I'm here to be your advocate and help protect you, and I will have to report it to the agencies. But we want to try to assure our patient that we will protect them and provide them with a safe place, etc., so that they are able to report to us what is going on. All right, social services that are available for the older adult. There's a wide variety of social services out there in the community that is funded by the state and the government and the country, the national services as well. The administration on the aging is one of them. It is a part of the Department of Health and Human Services, and the administration on aging is actually responsible for many of the older adult programs that are available in the community. Um, Title III and Title IV are two of the bigger acts, and Title III funds services like senior citizen centers, Meals on Wheels, and things like that. And then Title IV is funding for people to be trained and educated in the field of aging. So there's money out there that is allocated for older adult. And then we have Medicare and Medicaid. You need to know the distinction between Medicare and Medicaid. Medicaid is based on income, all right, And not all older adults are eligible for Medicaid, but some older adults are based upon their income. Medicare is based on age and health status. Um, I am unable to activate those videos for you while I'm doing this narration, but you are responsible for the material that is contained in both of those very brief 3 to 4 minutes, I think each one is on Medicare. Medicare is for individuals who are 65 or older, or those with chronic disabilities, including chronic renal failure. There are a couple of other diseases where even if you're younger than 65, you're eligible for Medicare health care services. But I'd like you to please take a look at that. You are responsible for that material. Okay, next slide. Some care alternatives for older adults. Again, we talked about this. I need to flip flop this. This is actually upside down. We've already talked about the fact that only about 5% of the older adult individuals live in long-term care facilities. And the way I have this labeled, it looks like the majority of them live in the long-term care facilities. So please, if you would, in your minds, flip-flop this triangle, recognizing that most of the older adults do in fact live at home. Some participate in daycare programs. Some receive home health care, and very few, 5% in fact, current data say are in long-term care facilities. All right, next slide. Okay, if we could think about some of the fears that patients and families have concerning nursing home placement, loss of independence, loss of autonomy. I lived in this house for 50 years. I'm going to be totally dependent on somebody to help me get out of bed. Lot of concerns. Am I going to be mistreated? Um, it's the stigma of being placed in a nursing home. So think about some of the fears and concerns that patients and families might have, and be sensitive to that when you're there visiting or caring for older adults in that setting. Also, think about the role that you can play in helping reduce the impact of institutionalization on the older adult and make it more of a positive environment for them. All right, we're talking about human flourishing. Even in the long-term care setting, we can encourage and facilitate human flourishing where we are promoting and stimulating socialization, where we're promoting self-respect, where we're promoting individuals feeling self-esteem, feeling good about themselves, about what they can do. And the nursing staff are very influential in this vein. Okay. Some challenges for gerontological nurses. We'll talk about this throughout the entire semester, but very often diseases are difficult to accurately diagnose with the older adult. A lot of times they don't report symptoms. Oh, they just think it's a part of old age. Oh, my knee is bothering me. Oh, I'm just getting older. Meanwhile, there's some arthritis going on that's becoming more acute, and perhaps that individual would benefit from some kind of physical therapy, from an anti-inflammatory, maybe just some instructions on how to rest the leg, the knee periodically, but they don't report the symptoms. They don't want to go to the doctor for one more thing. They don't want to uncover another problem. So they self-treat. They modify their habits so that they're not standing on that knee as much or relying on it as much. And again, they attribute it to old age. Another example of that would be an individual who begins to have more memory problems. There's no way I'm going to go to the doctor and have him or her tell me I have dementia or Alzheimer's disease. I don't want to know that. That's not me. That's not happening. So what do? I'm going to do my best to make sure that I'm going to make notes to myself. I'm going to make sure I've got a routine. I'm going to rely on help from my partner. So what this does is this kind of covers up lapses in memory where if the individual has reports to the healthcare provider, maybe some tests could be done. Maybe this individual would actually benefit from early medical treatment, from some of these new medications that are out for that enhance cognition. So the older adult misses out because they're covering up because um, they don't want to seek help. So we need to encourage our individual older adult patients to seek medical attention. Um, Another issue that's very common is that it's called atypical, with an A and then typical. Atypical or not typical manifestations of illnesses. The older adult often manifests disease symptoms that are not the usual symptoms that are manifested from younger adults. For example, an individual can just simply have an aching joint that might be actually a broken hip. Depression can be a form of dementia, delirium, or acute confusion. Very frequently is a clinical manifestation when an older adult has a urinary tract infection. Instead of having burning and urgency and frequency of urination, very often the older adult's first symptom that they have a UTI is in fact delirium. Also, lab values change with age. We use lab values a lot when we're trying to identify, what might be wrong with an individual. And because lab values change with the older adult, they're not as reliable an indice for us to use. Older adults often have myocardial infarctions with no pain. They can experience acute appendicitis with no localized abdominal discomfort. Typically, we'll have very clear indicators that that's got to be appendicitis. Well, the older adult doesn't present that way. Um, they may have no symptoms of acute appendicitis until perforation actually occurs. All right, so challenging population to care for. Next slide again is talking all about function. Um, when we are assessing our older adults, we need um, to do so very, very methodically. We want to make sure that our older adults are as um, we want to make sure that they're not anxious. We want to make sure that before we sit down and do an assessment, a physical assessment, we want to make sure that, do you need to use the restroom? All right. Are you warm? Are you comfortable? Are you in pain? All right. If we meet those basic needs first before we do our assessment, we're going to get a much clearer picture of exactly what is going on with our older adult. So, make sure that they have their assistive devices with them. Do you wear hearing aids? Where are they? Let's put them in before you begin your actual detailed assessment. Do you wear glasses? Let's put your glasses on you so that you and I can have better face-to-face communication. Everything that you can do to meet primary needs, make sure they have their assistive devices. Don't engage the individual. Excuse me, hold on 1 minute. Okay, so back to, sorry about that again, another interruption. Elements of assessment. What are the things that you're able to do for yourself? What kind of things do you need assistance with? Physical assessment, head to toe, mental status evaluation. What kinds of things that need to be done at home can you do for yourself? Can you write checks? Can you get to the grocery stores? This bottom one on the right, if you look down, SPICES, where you see sleep, problems eating, that's an acronym called SPICES. And the SPICES is a very fundamental screening tool that's evidence-based that identifies for us early on in our interaction with an older adult some of the potential problems that they might have that are related to geriatric syndromes, problems with sleep, problems eating, problems with incontinence, any issues related to confusion, any falling, and what's the potential for skin breakdown. So, um, that Spices tool is a very reliable and very specific to the older adult population, and you will be tested on knowing what that is. Okay, almost finished here. Okay, we need to manage our older adults. Our nursing diagnoses are going to be very similar to what they have been in the past. There are a few that are very specific to the older adult. We're going to plan our plan of care. We're going to include our older adult in the plan. What are their goals? What are realistic expectations for our individuals? Um, Including the caregivers when at all possible, whether it's a spouse or the children or a family member, including caregivers in the planning for our strategies for our older adult is very, very important. And always individualizing our care. No two older adults are alike. Things that are important to one person are not important to the other. Try to make that plan of care as individualized as possible. In the long-term care setting, it's not called a nursing care plan, it's called the I care plan. I, the patient, I, the resident, determine that this is my plan of care and these are the things that I want you to do to help me achieve this goal. And you'll see that in place in the long-term care setting. All right. The did I go out of order here, or do I just have another slide here? Anyway, this next slide that you see, nursing management of older adults. We are very often in the acute care setting their first point of contact, that is the nurses. Most often, older adults who come into the acute care setting are coming in with multi-system problems. They are high risks for surgery very frequently. They're very high risk for experiencing acute confusion or delirium when they come into the hospital. We're going to discuss in detail some of the symptoms that are associated with that and what we can do to help prevent that delirium from occurring. They're also at high risk for premature discharge. And, that's a huge issue for healthcare facilities today because if older adults or if anyone is readmitted to a healthcare to a hospital within 30 days of discharge with specific diagnoses, that hospital is not going to get reimbursed for that second admission. So we want to make sure that our older adults are not being discharged prematurely, that they're provided with the appropriate resources that they need to remain at home and manage that illness. Most older adults are qualify for rehabilitative services through Medicare. We want to make sure that their environmental safety is addressed before they go back home. Do a screening of the home environment. There are, resources through social services that are available to do that for us. Make sure we have addressed any assistive devices that might help. Look and screen for depression. Look and screen for sleep issues, etc. Make sure we realize that 35% of all prescription drugs in this country are consumed by older adults, and I have a feeling that number might be a little bit low. Um, Individuals who are 70 years or older take an average of 7 medications. Those who are older than 80 take an average of 12. This leads to an increase in adverse drug reactions that we as nurses need to be aware of and be continuously screening for. And recognize that adverse drug reactions, okay, because of this polypharmacy concept, all right, 12% of hospital admissions are related to polypharmacy and adverse drug reactions. So I find it quite alarming, and I hope that you do too. And again, awareness is a big part of it. This next screen, we've already talked about that. We did this in class, and that finishes up my continuation of our in-class presentation for week 1. I look forward to seeing everyone again week 2, and let me know if you have any questions about this presentation. You can email me, you can bring it to class, whatever you need to do, make sure your questions are addressed. Thank you.